you're going to be cranking up your therapy if you're not getting the response that you want. And as I understand it, your response is either a 30% reduction early on and then to a target later on. At some point, you may get to what's called a maximally targeted or maximally tolerated statin dose, right? So how do you define it? And then what do you do? First of all, how would you define a maximally tolerated statin dose? Anybody want to jump in on this?
Yeah, the maximally tolerated statin dose is the highest dose of a statin that a patient can tolerate, even if that dose is 0.
Okay, but what is tolerate? In other words, some patients say my joints hurt or my muscles hurt.
Then they can't tolerate.
Some people have word finding and they can't tell you how much they hurt.
Then they can't, then they can't tolerate it. So it's individualized. It's a patient-dependent metric.
So there's no form that you fill out. There's nothing that you can submit to the insurance.
Yeah, I would say the maximally tolerated dose is that at which the patient no longer will take the drug.
Okay.
That could be 0.
It could be 0.
It could be 80
because
milligrams.
Because they don't like it, because something's wrong.
Right.
They believe something's wrong.
And again, it depends on the company again, but I think most companies would just ask for a physician's statement saying that my patient is at maximally tolerated dose.
He's laughing at you.
He's laughing.
Easy, huh?
I've been the bad guy here. Seth, go ahead.
No, I
You don't
completely
think
agree
Seth's
with
been
you.
the bad guy too?
I'm the
Okay,
bad guy
fine.
too. But I completely agree with you. I think you should probably speak only for your own company, only because both Howard and I have had entirely different experiences with multiple companies where they do reject continuously prescriptions for PCSK9 inhibitors.
And the question is that the exception or is that the rule?
It's the rule. And so there are data that we now have that show that initial rejection rates are between 80 to 90% in the nation, and that overall in the commercial population, final approval rate is somewhere in the 30 to 50% range at most. And in the Medicare population, it's between 50 and 60% final approval after multiple appeals.
All right, well, let's get a handle on how many folks we're talking about altogether, right? Because under the current guidelines, if you will, or algorithms, you're not going to start giving these new drugs to people who are already controlled on previous therapies that are sometimes generic and sometimes easy to get. So what proportion of patients altogether have uncontrolled lipid levels on statins alone?
And your definition of uncontrolled means what?
What a good question. Why don't you define it?
Yeah, so it depends on the patient population, depends on the risk. Now, with PCSK9 inhibitors, all we're talking about is the high-risk patient. So all we're talking about is the ASCVD patient or the FH patient. And I would say greater than 70 would be not well controlled.
Okay.
What do you think the
Large
numbers
percentage.
are?
So a large
The numbers,
percentage.
well,
greater than 70%.
No, I
unfortunately,
think he was saying greater than 70
No, the
milligrams
number
per
of
deciliter.
deciliter.
Yeah,
Right.
so unfortunately, the latest NHANES data that just came out showed that only 20% of people with ASCVD are under 70.
And of the people, there was last year, they showed that only 30% of people on a statin get to the goal that they should.
Yeah.
All right,
And that's 70 some odd million people times 30%, you do the math.
So let's parse this out. If a fair number of high-risk folks on, and we'll use your definition of maximally tolerated statin dose, that is to say, they'll take it, don't get where we need them to go, then we go searching for some other therapy. And how do you track and how do you manage those folks?
Yeah, we as the insurance company generally don't unless we have unless the company has a very active disease management program. And again, that varies with companies. So we don't track it at that level. We expect the physicians to be tracking that and monitoring it and prescribing
But surely, an insurance company that's being asked to foot the bill for new expensive medications is tracking how many of those prescriptions are going out and how many are for reasonable reasons.
Yeah,
no?
I think we put considerable resource into promoting adherence of prescribed therapies. So, and also making recommendations to increase the dose where it's warranted, where the patient hasn't complained of problems on their current dose of statin and has the opportunity to increase it. We don't proactively track LDL levels, but certainly we're working with patients every day to identify patients who may not be adherent.
So let me see if I hear this. Somebody comes to you and says, I want to use this new expensive drug. Are you really going to go back and say, gee, they're not on a maximal statin dose yet. Is that what you're saying?
Yes.
Okay, is that fair?
We may ask the question, what have you tried in the past, and how are you taking your current medications?
May ask that question.
We're going to look at, we will. We're going to look at claims data. We will. But
You're not only, wait a second, you're not only going to ask that question, you're going to ask for documentation that the patient has been on more than one statin for a prolonged period of time. And if you can't meet those criteria, they're not going to get the piece.
Is that what you're talking about, the receipts?
Yeah.
That's the receipts you were talking about.
Or sometimes
or
even a note.
records.
You'll write a note that says that the patient has been on whatever statin for 2-3 months, and they're going to say, that's not good enough.
They don't
we
believe
want to
it.
see receipts that he actually bought the medicine.
But is that unfair? In other words,
Yes.
if you're going to say, look, the statin's not working, please give me an expensive drug, is it unfair of them to say, is he taking the drug?
Of course it's unfair because the FDA has approved these drugs for that indication, and we are the doctors, and we're
What
taking
indication?
care.
I'm not taking the drug?
No. If they're not taking the drug, they're not taking the drug for a reason. We as the physicians should have that conversation with the patient, and there needs to be some sense of our respectability, that we're actually doing the right thing.
Okay.
At some point we have to say, doctors are not so
And
I
bad.
appreciate that perspective, but if we were to show you pharmacy claims data that demonstrate the patient hasn't actually been taking their statin.
So then come back to us with that.
Right.
Rather than asking us to go to a patient who looks at me like I might as well have asked him for his childhood underwear. I mean, it's just, they're not going to, this is not going to be
Well,
there.
how do you identify patients who may need more aggressive therapy anyway?
So-
is it simply a number, or do you really drill into it and say, are you really taking the drug?
Well, yes, many times when you get a sub-max, you get an unexpectedly mediocre response to a drug, you want to know, so you ask the question, how many days a week aren't you using the drug? Not are you taking it, but how, and they go look at you, I miss it once or twice. How often? 3 times a week. They'll come out with that. But other patients will look at you, and after taking histories for 34 years, you get reasonably good at knowing when someone's lying. And they look at you totally honest and saying, I take it every day.
Okay. Of course, if you have to give this drug by injection, they have to come and get it. You've got very good records going forward.
No, they
Self-injected.
They
self-inject.
Yep.
Okay.
Yep.
So,
But I could just push back on something. You said you thought it was unfair to ask a physician and a patient to mutually agree to take a much more cost-effective product, all things being equal, that they could take it without side effects. You thought it was unfair for us as an insurance company, a managed care company, to ask that be done. And
No, I didn't.
Okay,
No. I said if we say it's been done, it's unfair for you to say, well, we need to see the receipts because we don't believe you.
Okay, so you would agree
Oh,
then
absolutely.
that it's
Oh, absolutely.
fair.
That's the That's the PI though. So the PI is on maximally tolerated statin therapy, and if they haven't been on maximally tolerated statin therapy, you're right.
Okay.
so basically, if I give you my word under the Boy Scout or Girl Scout, if there is one, oath, this is what's happened, and then you come back and say, yeah, well, where are the receipts?
Right.
They say it's unfair. Is it fair or not?
I'll say that sounds unfair. That's an incredibly strict criteria that I haven't seen receipts from 5 years ago or prescription record.
I couldn't make that
we go
stuff
by
up.
prescription records or physician attestation.
We
So-
see this, I'm telling you, all day long.